Started. So as you all know from our meeting that we just had, Dr. Piccirillo was going to come talk with us about systematic reviews, but it didn't quite work out so well, and so it really gives me great pleasure that we have an opportunity to have Jay bring us up to speed sort of on systematic reviews as we think to the JCIH going forward over the coming years. So for those who don't know, Dr. Piccirillo is a professor here in the Department of Otolaryngology at WashU, and he's also our vice chair for research. Beyond that, he's actually the editor for JAMA Otolaryngology, head and neck surgery, and so he has extensive real background in systematic reviews, being a journal editor, understanding sort of data quality and presentation. And so I really thought he was the perfect person to come try and bring the whole group up to speed on thinking about how we look to the JCIH going forward. So without any further ado, Jay, take it away.
Great. Thank you, Craig. It's a real pleasure to present this topic on improving health policy recommendations through the use of systematic reviews. And I apologize for missing you all in person in Chicago, but the technology will allow us to bring this presentation second best way of doing it. Okay. So the idea that Craig charged me with was to give a little bit of background about some of the challenges that we face as we try to set health policy based on research, and how systematic reviews can help put the literature together in such a way that we can make meaning of it, and more importantly, make policy from it. And the whole last part of the talk really goes over some of the topics important to infant hearing in areas that might be ripe for systematic review type methodology. So without further ado, let me go ahead and get started. I think there's opportunities to ask questions either through your computer typing, or we've got plenty of time at the end for just doing it over the telephone. So about 10 years ago, there was an article by Chalmers and Glasgow that was pretty famous, or infamous, if you will, estimating that nearly 85% of the public and private money spent on biomedical research, things like NIH funding, were wasted because of inadequately produced and reported research. And they felt very strongly that this waste was slowing the improvement in patient care. And they identified four main areas of waste in the production and reporting of research. One was, first of all, choosing the wrong question. Number two, doing studies that are unnecessarily or poorly designed. Failure to publish relevant research findings promptly. And finally, biased or unusable reports of research. And they concluded by saying, without accessible and usable reports, research cannot help patients and their clinicians, nor help set health policy. My colleagues and I at JAMA Otolaryngology followed up that paper with an investigation in otolaryngology itself, and we identified 6 themes that we felt were impeding the translation of research into patient care and health policy. And here are the 6 themes. Excess focus on basic explicative or discovery research questions. And linked to that is number 2, not asking the right clinical research questions. That is, questions that are relevant to patients and clinicians. Number 3, poorly designed or executed research. 4, not publishing completed research. 5, incorrect, unclear, or biased reporting. And finally, failure to disseminate and implement the important findings. And we had a figure shown here that then proposed some solutions to these 6 research waste areas. And if we start down at the bottom, we have excess focus on basic science as a research waste challenge. The proposed solution: direct more funding support towards clinical, translational, and dissemination and implementation research. For the problem of not asking the right clinical question, well, we should investigate questions that are of more interest to patients and clinicians. In other words, engage our stakeholders at the very beginning of our planning of research. Poorly designed or executed research could be corrected by more emphasis on proper research methodology and biostatistical training. Many of our programs have these type of clinical research training programs now. 4th, not publishing completed research. All research, whether it's negative or positive, regardless, should be published in some place where the public can see what has been already accomplished. Number 5, incorrect, unclear, or biased reporting. Well, insist that published results include effect sizes and confidence intervals and determinations of what's clinically meaningful, and stop relying so much on p-values when reporting results. And then finally, the failure to disseminate and implement important research findings. The proposed solution was for all of us to develop standardized procedures to implement the research findings into clinical practice. How can we translate advances at the bedside to, advances at the benchtop or in research to the bedside? And this slide puts it together, the proposed solutions, in a slightly different way. Well, even if we were to address and do all of these 6 different solutions, we would still have persistent challenges in using research to take care of patients or to improve patient cares. And that is the challenge of translating research into improved patient care lies with the problem of the single study. It's very challenging to get meaningful information from a single study. And why is that? 4 main limitations of the single study. A single trial with a small sample size may show a statistically significant effect of the intervention. However, that positive study with small sample sizes are especially vulnerable to chance and may in fact just represent a false positive. Likewise, or contrawise, a single trial with a small sample size may show no statistically significant treatment effect when in fact such an effect exists, and that this would represent a false negative study. And finally, the number of subjects enrolled in clinical studies is often inadequate to detect clinically meaningful differences. And if statistically significant differences are detected, they most likely represent chance effects. So what's the solution? The solution is to rely more on these systematic reviews, which are attempts to collate all the evidence that's been produced and that fits pre-specified eligibility criteria to answer a specific research question with more reliable findings. It uses explicit methods, systematic methods that are selected with the view to minimizing bias. And the characteristics of systematic reviews are as follows. Number 1, first, a clearly stated set of objectives with an explicit and reproducible methodology must be used. A systematic search of the published literature and even other sources must be done to identify all studies that would meet the eligibility criteria. Number 3, for the studies that are identified, some type of assessment of the validity of the findings. For example, through assessment of risk of bias. And there are now many different nationwide or international organizations. One of them is the Equator Organization that sets out the research methodology for systematic reviews and all the other different types of research designs. And they really should be viewed as guiding principles for those of us who are doing systematic reviews or want to do them and want to evaluate them. And then finally, number 4, systematic presentation and synthesis of the characteristics and findings of the included studies are very, very important. So a systematic review may or may not include what's called a meta-analysis. A meta-analysis is a very formal statistical analysis of the results from independent studies, particularly when those studies are randomized clinical trials, and they generally aim to produce a single estimate of a treatment effect. But so much of clinical research doesn't involve randomized clinical trials, and oftentimes meta-analyses are just not appropriate. When we do systematic reviews, we need to make sure, are we synthesizing evidence from randomized clinical trials or non-randomized or observational studies? Here's an example of a systematic review recently published on universal newborn screening. I'm sorry, it was published in 2008. Universal newborn hearing screening, a systematic review to update the 2001 U.S. Preventive Services Task Force requirement. So the U.S. PSTF does lots of different systematic reviews, and they really have done a great job with their methodology and their reporting on systematic reviews. And in this case, it's on universal newborn hearing screening. So let me just summarize the points I've made. Systematic reviews are essential tools for healthcare workers, researchers, consumers, and policymakers. Systematic reviews allow for more objective, transparent appraisal of the evidence than traditional narratives, and they give us so much more information than just the single study. Systematic reviews can be used to resolve uncertainty between single original research studies, reviews, and when editors themselves disagree. And Finally, systematic reviews may demonstrate the lack of adequate evidence and thus identify areas where future or further studies are needed. What I've done here in the last two slides is put together what you all identified on your Joint Committee of Infant Hearing monograph, the 2018 position statement. And these are the infant hearing research needs. This slide and the next identify the 6 areas. Number 1, continued and accelerated research into optimizing screening, diagnostic, and amplification intervention protocols. 2, exploration of preschool hearing screening programs to determine the ability to identify late onset or missed hearing loss. Increase longitudinal research on the efficacy and quality of early intervention studies to assure optimal outcomes for children who are deaf or hard of hearing. 4, increased inquiry and study of the cost utility benefit of early hearing detection intervention programs. 5, focused research on the impact of social determinants of health outcomes relative to deafness or hearing loss. And then finally, further examination and delineation of health disparities due to geographic location and other types of factors. And so, to conclude, I'd like to open it up to discussion where all you think systematic reviews could help with your work in health policy and health outcomes, and take questions about, again, methodology or areas of interest and things like that. Craig?
Yeah, that's great. Thanks, Jay. You know, I think, I don't know, maybe Jay, you can comment on this, but you know, the typical way that we've done our review over the last, 10 or 15 years has basically been an opinion-based review that was basically non-systematic. I mean, what are the potential downsides of doing what we did or what we've done in the past? And maybe from a journal editor perspective, you know, why do you think we've had some difficulty in getting something like that published?
So I think from my standpoint, what I really like to see is as I mentioned, the 4 points: a clear and explicit, focused research question. What is the question? And then a valid, thorough review of the published literature. Oftentimes that involves using research librarians who identify mesh headings, who can search the usual PubMed databases, but also other databases that are out there that might contain articles or literature that you'd want to include. Equally important then is the synthesis of that literature using these guidelines like I talked about, the Equator Research Methodology Guidelines for assessment of the validity. You know, not all single study research studies are created equal. And we really need to look at each article and grade its methodology and whether or not it's valid and should even be considered in a meta-analysis or a systematic review. And then finally, some way of putting that data all together, whether it's through forest plots or different types of quantitative measures. That's what I really like to see as an editor. We also have Dorina Calgera with us today. Dorina's in our department as our research statistician. She's also the research statistician for JAMA Otolaryngology. She does a lot with our authors on systematic reviews. Dorina, is there anything you wanted to add to that? You know, Dr. Buckman asked, what do we look for in systematic reviews? And I identified the 4 areas, things you might think of.
I would only add a little bit more stress on the way how the evidence is summarized in systematic, in fact-based and conclusions based on systematic methods and facts-based evidence provided from these systematic reviews. And this is where I see the biggest difference between opinion-guided summaries and methodology-based systematic reviews.
A lot of the guideline organizations, and again, the first and foremost is the United States Preventive Task Force, I believe they limit very strongly the number of clinical experts that can be on their guideline panels, and instead enroll research methodologists, people who really know the methodology much more than the clinical topic. And that may sound a little counterintuitive, but what happens with some of these guideline panels is that when you bring in more clinical experts, they really all come with their own clinical opinions, and that's what we all have. We all have our biases from what we do. There's no way of getting around it. And so one of the ways of getting around that is to limit the number of clinical experts or opinion leaders that are involved in the creation of these guidelines. Does that make sense?
Yeah. Questions for Dr. Piccirillo? I mean, I think our charge is really to identify what the questions are that we really want to try and answer going forward. I think we touched on them a little bit there, but I'd be interested to hear other people's thoughts.
Hi, I actually have a question. This is Tawny Holmes calling, and I am with the Association for the Deaf, and I have a question about the bias for the systematic review and how that can help reduce the bias in the methodology. But I was also wondering how this relates to cultural identity, and I'm wanting to make sure that that biases don't actually happen in the methodology itself, or in other situations. Could it be more of a perspective point of view? Give me one moment, please.
Sure. Mm-hmm.
They're talking about systematic bias. So maybe like not including all the literature, or you know, yeah.
Okay, so one of the questions that we were speaking about, doing the screening before the 6-month-old, and so thinking about maybe, I feel like Amish don't do the hearing screening, so with the methodology, I feel like should focus more on that group of people and how maybe that could actually affect the research for the early intervention hearing test. Does that make sense? Is that more clear?
Well, so if I understand, a challenge with systematic reviews or any systematic review of the literature is that you can only review that which is published, or that which is available. And as an editor, I know that there's a real strong publication bias. Certain manuscripts, particularly those who report negative studies, are much less likely to get published. So there's a huge bias there with regards to what's available to review. Now, with regards to particular areas like the Amish or culture, I don't know how that would work, but we are very cautious about making sure that we try to find all the articles that are out there to include into the systematic review. Craig, do you want to?
Yeah, I mean, Tawny, to your point, I think your point's really an excellent one. I think what you're getting at is when you think about our document that we've worked so hard to produce, I think it's highly likely that our culmination or summarizing of the literature is probably biased. It's biased because we didn't take a systematic review approach to it. It never has been taken in the past. And so that's the reason for getting Dr. Piccirillo and starting to think about things in this way, is because I think we need to work harder to try and summarize the literature as a whole, rather than trying to be, rather than using sort of an opinion-based fact-finding approach. And I think we all are at risk for bias because we all have beliefs from the outset as to what we think is right or wrong. And it's really been very interesting to me over the years as I read these systematic reviews that oftentimes the sort of the conclusions that I've sort of taken for granted are maybe not necessarily the case once you see the totality of the literature summarized. So I think this is a huge opportunity for all of us on the JCIH to start to think about the literature that's pertinent in a different way.
I'd like to maybe answer your question in a slightly different way and go back to this slide right here, the summary points of the systematic review. If you look at the 4th bullet point, it says systematic reviews may demonstrate the lack of adequate evidence and thus identify areas where further studies are needed. So it may be that through the process of doing a systematic review, we might be able to identify that certain populations like the Amish or some other areas are not being studied. And there is a gap in the literature, a gap in knowledge that can only be filled by doing that type of research in the future. So that's another benefit of the systematic reviews, is to identify where there's a gap in knowledge. Torina, yeah.
And if I may add only a little point here is, even when you summarize all the available published work, you should also acknowledge biases and limitations of each individual article. They are weighted different ways through systematic reviews and statistical methods associated with it. And different studies, different conclusions are given different weight. And I think this is another one of the strengths of the systematic review analysis that is needed to guide this policy in the future.
Yeah, I mean, just to say the obvious, the reason why our academy would not endorse our document was because the lack of a systematic review.
Wow. That's unfortunate.
Yeah. Other comments or questions?
This is Rachel. I have basically a functional question when I'm thinking about JCIH and moving forward and talking about maybe breaking into smaller groups to do more piecemeal work. How are we actually going to implement systematic review? Are we going to try to take advantage of our academy's institutions that we're affiliated with to see if we can get assistance there? Are we thinking about hiring somebody? Are we thinking about? It just seems like it's going to be something that would be a big task for the members of JCIH to do alone.
Yeah, I guess we know our academy has some infrastructure. I mean, we have some infrastructure in our department, but I would say that we're going to need to identify resources to be able to make this happen. And I would also say that we're probably going to need to go back to our individual organizations and sort of clarify what the problems we had with getting our last document endorsed and published. And moving forward, it's probably going to require a greater investment by them to try and move this field forward. I don't know. I mean, it'd be interesting in other people's thoughts.
This is Allison, and I totally agree with what you're saying, Craig. I mean, these things are time-consuming. They're expensive. We have, for those of us in academic medical centers, we have the resources to go to our libraries. But even then, there is, libraries are now recharging the department to do systematic reviews. So I think, the resources are there, but they don't come without dollars attached. I think the other point to the and I'm sorry, I don't remember who the first person who was asking a question was. I'm so sorry. That some of the very work that we would like to cite and discuss and acknowledge has not been published in peer-reviewed journals, and so that ends up. I think it ends up perhaps biasing, for want of a better term. It biases the literature that we can review, because some very important things have been published, but they haven't been published in journals that lend themselves to to this kind of scrutiny, or that have gone through peer review, et cetera, et cetera. And I think that that's always going to be something that we have to acknowledge and be cognizant of and weigh in some way as we write our statements going forward.
For me, I think the critical factor is going to be identifying the questions that we really, really, really feel are critical to this field. I mean, I really feel like we're going to need to maybe spend our next meeting or maybe some time in between really identifying what are the critical research questions that we need to answer to move this field forward, rather than rather than getting stalled out.
Absolutely, a great idea. Define what the questions are, define what's really important to the organization, and then search the literature, see what evidence is available. And again, it may actually be that you would commission research to be done to fill those gaps. You may not be able to do systematic reviews for some of those questions because the literature base of published medical research just can't support it. And in that case, you would begin with some individual research studies first. So I think, like Craig said, the most important thing is to find what the questions are and then search the literature to see what the research database looks like. And then where you can go forward with the systematic review, go for it. And where you can't, begin to ask for research, like I talked about the topics for NIH funding. What should the NIH be funding? Well, you guys, your organization could come forward with a list of areas that are important questions that currently can't be answered because the research base won't support that. And that would be a good advocacy point for the organization too, for health policy.
Other questions or comments? Susan, any thoughts? Susan Wiley?
Yeah, well, I mean, pretty similar along the lines of, I think, what's already been talked about. I think just to also kind of the first concern around, like, kind of cultural biases, I think to some degree there may be more in the qualitative research domain that kind of can be looked at, and disparities and that sort of thing. I think small focused questions are going to have the biggest bang. I think if we know, I mean, most of us will kind of go in thinking about what we think already exists. We're going to find things that we didn't know exist when we do it in a systematic way. And maybe starting with questions that we think have enough to actually get us somewhere. So if we're pretty certain there's limited data to support something, we might not start there in our first trial of this, because we're not going to really, what we'll come up with is there were 3 studies.
Right.
So, I think that trying to think of something that's small enough but rich enough in the literature to kind of get some traction might be a good starting place.
Other thoughts?
This is Karen Munoz. I would just agree with what Susan said. I think we want to start somewhere where we think that quite a bit has been done, and because there's going to be a number of areas I think that we care about where we're going to find that more research is needed. So,
yeah.
And this is Rachel. Just to piggyback on that, I think one of the things that we should, I think, keep on the front of the radar screen moving forward, just because we've gotten such ongoing and persistent requests from our practicing community, are the risk factors, because that's something that would benefit tremendously, I think, from systematic review in terms of looking at what's there. And there's probably not going to be a ton, because this group has always taken the lead in manufacturing those, so to speak. But that's something that the clinical practicing body continues to ask for a lot, and it's going to be something that's going to need updating as we move forward. So that might be something that we don't necessarily want to let slip off the radar screen.
Yeah, I think many of them. Oh, go ahead, please.
Oh, sorry.
Go ahead.
Oh, I've thought about that a lot, and you almost have to go condition by condition for the risk factors for the monitoring, because, so I think, do we pick one and really give the true evidence behind it?
That's a great point.
It seems a little bit like a daunting task, but recognize it took us 12 years to get out a statement. So if we published 1 or 2 of these a year, I mean, maybe 1 a year, we would be making enormous progress. It's sort of daunting to think about the entire document and thinking about doing systematic reviews across all of it. But I think if we just start to bite off little pieces, like the risk factors is really just a fantastic one. Many of the medical areas actually do lend themselves to systematic reviews. I think audiology actually does too, to some extent. So I think we really need to start to think about how we're going to break up and topics that we should take on, and then based on the topic, then we can identify what's the scope of work look like, and maybe who would be willing to fund it. I do think that we each need to go back to our organizations and have a conversation regarding the way that we're thinking based on what happened to our publication this go round, and the concern that we need a much more systematic approach to our process, and then tell them that it's probably going to cost a bit more money to do this sort of thing, but we really are we're very committed to it.
And this is Rachel. I think one last thing I would throw out, and this really goes back to, I think, Tawny's original comment regarding some of the bias and the cultural piece. I think the timeliness of this talk is interesting. I've gotten several requests over the last couple of weeks from people who are interested in doing some kind of meta review or systematic review about visual spoken language bilingualism. And it's something that obviously there's been a lot of discussion within our group about it. There's been a ton of discussion outside the group. And I think that's a big one to tackle, but I think once we start doing this and have a system for it and feel more comfortable with it, that might be really, really productive for our group to look at the body of literature, because it's finite in terms of peer-reviewed stuff. But I think that might be really worthwhile for the providers out there and for families too.
Seems like a great focus.
Great.
Yeah.
Great. Other comments or no? Okay. Well, listen,
yes.
Oh, go ahead, please.
Connie,
Yeah.
that last comment, I think the concern that I would have is there would need to be a check on funding in order to have that research, because it could be possible to lead with bias within the research. So, especially with the population of those who have cochlear implants, the funding for that would be specific to that population of people, and they would lead with the bias of, those who are implanted versus those who are unimplanted. And because of that concern, the number of research related to the quantity of the research related to the language hold on one moment. For the mainstream versus right now, there's not a high percentage. There's a lot of percentage of babies that are born deaf, and the audiologists are not informing the people, so there's not a way for them to get the information that they need, so they're stuck and they're following a bias without knowing. The system is small. And also, in the long run, the study, the lingual study, I'm not sure how that systematic approach will help the bias.
Connie, this is Rachel. You bring up a really good point, and I think one of the things that a systematic review will help with is clarifying where the bias is, for just some of the reasons that Jay mentioned, where we look at the literature and we see what's available regarding children who use both spoken and sign language and what are the outcomes. You have to look at what those studies focus on. So if 90% of the studies are within one population group, such as cochlear implant, I'll use as an example because you did a good example. If you find that almost all the studies are focused around that, that's identifying bias.
Correct.
And that's
Exactly.
something you can speak to in a systematic review. You can actually illuminate that the fact that the current reviewed literature leans one way and we need more studies with a more diverse patient population. So I think your concerns are actually what I'm thinking about holding up to the light in a
Right.
systematic review.
Right.
Yeah, in fact, that's the advantage of doing a systematic review, is that we identify those areas that are not being adequately covered. So,
Yep.
any other comments? Okay. Well, listen, I would like to thank Dr. Piccirillo for help bringing this, to a bit more light. And I'll send out an email here going forward over the next few days to come up with some, sort of our next steps forward in thinking about how to do this. But I think what it's going to really boil down to is each of us talking to our parent organizations about our thinking in terms of being more systematic in our reviews, and also, the trouble that we had with our past document getting published, which we still are working on, of course. And then maybe what we'll do is we'll plan on another conference call in about 4 weeks, as we start to think carefully about what our next, maybe what our next question or questions are. Okay, so thanks everybody for joining us.
Thank you very much.
Thank you. Yeah, thank you.
Have a
very
great
much.
afternoon.
Thank you.
See ya.